Hi, Dr. Volchak here. This is an introductory module on assessment of lower extremity perfusion. This is specific to examining a patient for adequate arterial blood flow in the context of wound healing. The main tool that we use here at WCE for screening patients and determining if there is adequate blood flow to perfuse the lower extremity for wound healing is the ankle brachial index, or ABI. This is a good tool for assessing blood flow in the lower extremity. It is a numeric value that represents blood flow to the leg compared to blood flow to the patient's arm. This ratio, or pressure index, is determined by taking the ankle systolic, dividing that by the brachial systolic pressure. Typically, we will look at blood pressures obtained at the brachial as well as the posterior tibial and the anterior tibial, or dorsalis pedis. If the ABI is not possible because of a wound at the location where the cuff would be used, there is the alternative, which is the TBI, or the toe brachial index. If there is a patient that has what we call non-compressible arteries, or an abnormally elevated ABI higher than would be expected, the TBI is more accurate in giving an idea of blood flow at the foot. Here at WCE, we use an automated system called Smart ABI. This uses blood pressure cuffs at the arm and the ankles to calculate and record the changes in volume of blood below the cuff in the extremity. This gives us an idea of the perfusion. There's also a cuff for the toe. We'll talk more about this in a little bit. In regards to the Smart ABI, there will be a link in the materials at the end of the presentation that is an overview of the information that comes back on the report that the system generates. So when should we think about doing a Smart ABI? All lower extremity wounds should have an ABI performed unless there is another vascular study that has been recently performed, such as a vascular ultrasound or CTA, etc. Any new lower extremity wound in a patient that you've been following, and any recurrent lower extremity wound that occurs, as well as screening every 6 months in this population. So always get this on the first visit, and always get a TBI as well as the ABI, because this will give you additional information that is not always apparent with just the ABI. The ABI is a screening tool, as I've said before. It can be falsely negative. The Smart ABI machine graphs out the change in volume of blood in the limb. This is because air is displaced when the cuff is applied, and the computer uses an analysis and math to then graph a waveform. This waveform is something referred to as a pulse volume record, or a PVR. And in the case of the toe, there is a slight variation where instead of using air displacement, there's light being used. So it's a photoplasmography, or a PPG waveform that's being generated. So remember, these are screening. These are not definitive diagnostic, and they have a lower sensitivity. And when we use such a screening tool, we need to err on the side of getting further studies if there is something that is abnormal appearing, because we may be incorrectly identifying patients as not having disease when in fact they do have some peripheral arterial disease. So with the Smart ABI and other systems, we are generating waveforms at the ankle and the toe, and these provide additional information on the hemodynamics. As I said before, the anterior tibial and posterior tibial arteries supply blood flow to the foot. The medial and lateral plantar arteries come off the posterior tibial and are the dominant blood supply to the toes, while the anterior tibial and dorsalis pedis supplies blood to the dorsal aspect of the foot. Because the ABI is just a number, it's only one piece of available information. The PVR or the PPG waveform provides much more detailed information about the blood flow or restrictions to flow. We can think of a PVR waveform as an EKG, and with an EKG, we get heart rate. That's equivalent to the ABI. It's just a number, but it doesn't tell us anything about the intrinsic cardiac function or disease. Similarly, the ABI doesn't tell us the degree of flow restriction or where that might be. The waveforms can give us that information. And so it's important to look at the waveforms. And when you are performing a reading, and that's what you're billing for when you bill for an ABI reading, you are looking at the waveforms, which give you information about the flow. So we look at the amplitude, which is the vertical axis. We look at the time, which is the horizontal axis, the waveform shape, and then distortions in the waveform. Typically, a normal waveform will have a steep upstroke. There will then be a very well-defined peak, a dichroic notch, and a bowing to the downslope. These are all items that we'll examine here in a moment. Abnormal waveforms can be a variety of different characteristics, from completely absent to just slight abnormality where the waveform becomes biphasic instead of triphasic. And there's a degree of severity in the restriction to flow that occurs. So we're looking at the upslope, the peak, the downslope, that notch or the diastolic reflective wave that occurs. And as peripheral arterial disease gets worse, the waves will get shorter, so the peak is not as high, and the waveform across the cardiac cycle will become broader, or on the horizontal axis, we see a lengthening and the time is longer. So here on this slide, we have in the top left corner a normal waveform. We then start to get some broadening and decrease in the peak, which is mild disease. There is then the type C, where we get moderate peripheral arterial disease, and severe, where the waveform is really flattened almost to non-existent. So a normal waveform, we're going to see that sharp upstroke. We're going to have a nice peak at systole. There's going to be then a downstroke, which is the second peak occurring in diastole, and then a small second peak. That's a triphasic waveform, which is what would be normal, as compared to a biphasic, where we get a sharp upstroke, we get one upper peak, and we get a little bit of a pitting, but we don't see the same triphasic shape. That's more of a biphasic, which is a mild disease. There's also a weak biphasic, where we really get very little diastolic pit occurring, and this is more consistent with moderate disease, as opposed to a monophasic, where we just get the one sound. If you were listening on Doppler, no pitting, and we start to get some widening of the waveform. We also talk about dampened or monophasic. These are waveforms that are overall rounded and shortened. These are with more severe disease. So what types of waveforms do we see with the SMART ABI system? Well, we see a type 1, which is a triphasic normal. We can then see some mild disease where we're starting to get a biphasic waveform, as opposed to a monophasic where there's really only one peak occurring. That's a more moderate disease. And then a monophasic rounded type of a waveform, which occurs with more severe peripheral vascular disease. PPG waveforms are slightly different. This has to do with the technical method and the mathematic calculation that is occurring for the graphing. But what we see with normal is a dichrotic notch with a slight bounce occurring after it. You see that right here, as opposed to a type 1 where we're starting to get some mild disease where we don't get that upward bounce. And then in the more severe, this is completely lost and we have just a monophasic type of appearance. All right, so looking at a couple of waveforms that come from the smart ABI system, there is the original volume pulse recording, or PVR. This is primarily what we're talking about and looking at. There are mathematical recalculations that occur that give first derivative. That's as you would expect from calculus. We don't really look at those to any great extent. What we're more interested in is the original PVR, and there are the normal, the acceptable, borderline, defined, and severe, which are variations in those waveforms. There's a table here in this presentation which gives you an idea of the ABI ranges and pictorial representation of the degree of stenosis that's occurring. Similarly, the TBI numbers, these are for reference. So the ABI can mislead or trick us on occasion. This is why it's always important to look at the waveforms and also look at the TBI waveforms and the TBI number, as well as the patient's medical history. So don't get tricked by falsely elevated ABIs. Those are typically greater than 1.3, 1.4, which is failure to compress the vessels or non-compressibility. An ABI that is apparently normal, let's say 1 to 1.2, but the waveforms are markedly abnormal. This can occur because it is a mathematical calculation. It doesn't necessarily reflect what's actually happening hemodynamically in all instances. So it's important to look at the waveforms and ensure that those are the expected triphasic. So an ABI could be normal and the TBI could be markedly abnormal. Don't get misled by that. There are instances where maybe an ABI is normal, but the waveforms are monophasic. Also, as we talked about non-compressibility or diabetics with elevated ABIs, these are all areas where we could be misled by what appears to be a normal ABI when in fact there's underlying disease. The default should be, if you are concerned that there's some abnormality in the waveform of the ABI or the ABI number itself in the context of the clinical factors for the patient, we should reflex to a more formal vascular study. The Smart ABI has a whole bunch of information on it. This is good. There's more detail on these additional pieces of information if you want to go into those, but for the purposes of wound care and for the purposes of screening patients to ensure that they have adequate blood flow to their lower extremity, we don't really need to look at anything other than the ABI number, the TBI number, and the waveforms that go along with that. There's a couple of caveats that I'll let you know here. One of those is that if you have a decrease in the blood pressure of 20 millimeters of mercury or more between level above and the level that you're measuring at, or difference between the right and left extremity of 20, that is considered a significant decrease. And if that's the only change that you're seeing, that is symptomatic potentially for that patient and should have a heightened threshold for getting a more formal study. Always go with your waveforms. Those are going to be more diagnostic than just the number itself. Some things to keep in mind in terms of the minimum TBI or ABI for a wound to heal. TBI is greater than zero point 0.3 and ABI greater than zero point 0.6. What about compression for venous disease where maybe there's some underlying arterial disease as well? Don't use compression if the ABI is less than zero point 0.6. Also, don't debride infect unless it's infected necrosis that you're concerned about if the ABI is less than zero point 0.5. How about changes in ABIs when you're getting a follow-up ABI in a patient that you've seen in the past? Typically, the literature will talk about a change of 0.15 in the ABI from a prior recording as being a significant finding for disease progression. Those are some numbers to keep in mind. All right, reading and coding. So when we get a SMART ABI and you get a report handed to you, take a look at that and look to make sure that the study is complete, i.e., there are waveforms at all the levels that we expect, and that those waveforms are graphs that you can actually read, i.e., they're not so distorted that there's no information that's useful there. Are you looking at one level, i.e., just the ankle, or are you looking at two levels, the ankle and the toe? Did you look at the waveforms and make an interpretation of those? If you just report the ABI or TBI number in your note, that's not a billable reading. You must review and report your waveform interpretation. The CPT code that we use is 93922. This may not be apparent in Wound Expert, but that's the code that is entered into the billing system when we bill. So more on that later. There is a additional documentation tab in Wound Expert that's been created, and I'll show you how to work through that to do a correct reading. All right, here is a normal right ankle PVR at the DP and a right ankle PVR at the posterior tib in a triphasic waveform. This is a good normal perfused lower extremity. Here is a patient that has normal ABI by numbers, and their TBIs are abnormal. You can see how these waves are monophasic. They are shortened and widened. Here's a patient where if you look at just the ABI, 1.18 and 1.20, you would think that this patient has perfectly normal perfusion to their foot. However, you see that their right TBI is markedly abnormal, and this would be a patient that you should refer to a vascular surgeon for further evaluation and possible intervention. As I said before, flat, wide waves, those are concerned. Here's what you start to see. You almost have only two waves here, this wave and this wave, as opposed to the left, which is more normal. Here is abnormal right and left waves and corresponding decrease index. Let's say that the ABI is around 0.9, but the waveforms, as you can see here for the right and left, more so on the left ankle, are severely dampened, and this corresponds with the TBI being abnormal as well. This is a patient where we would want to get a more formal vascular study. Here's an instance where the right TBI and the right waveforms are markedly dampened, almost to the point of being non-diagnostic, as you can see here, as compared to those on the left, which are more consistent with triphasic. This is a patient where the arm waveforms are also flat significantly, and this may be one where it's a patient variable from, say, cardiac output or some such condition, or there may have been some error in the test being performed itself. So if this patient's still in the office, you would consider having it repeated, and this is most likely a user error type of thing because you are having normal waveforms at the ankle on one side, but your arm and leg waveforms are all markedly flattened. This would be consistent with a potentially non-diagnostic study, which should be repeated or perhaps reflexed to a more formal study. So in the Wound Expert, if you go under additional documents in your progress note, there is one called ABI non-invasive arterial exam. This is where you would be picking if you did a single level at the ankle or the toe or multi-level ankle and toe. You then would be entering the ABI numbers. You would be determining what types of waveforms there are for the right and left DP and PT. Also entering the TBI numbers, what your determination of the waveform pattern is, as well as your findings. This will then generate a study reading, which has your report, your findings, and your impression. It is important to have all of these elements to be billing for a formal ABI study. Otherwise, the ABI values and information just simply become part of your evaluation and not a separately coded or billed service. So, in conclusion, anytime that there's abnormality or concern, especially in the context of our patient population that we're trying to heal a wound, getting a more formal study or vascular surgery consult is imperative.